as I begin, and no financial relationships. So yeah, today's sort of the introductory talk, talking about kind of treatment and its barriers. So just going to present a bird's eye view before we start going more in depth, starting next week, really, and exploring buprenorphine and all aspects of treatment with buprenorphine. So today is kind of an introductory talk. I want to be sure to be done by 12:30 for the case. So we will kind of go through it, at a pretty brisk pace. So we're going to start by talking about a little bit about epidemiology and how that should inform our clinical practice. We'll talk about some treatment options and identify barriers to treating opioid use disorder in our practice. So starting with epidemiology, I mean, I think it's no surprise to any of us working either as clinicians or just being members of the community that opioid use disorder is indeed, as has been termed, an epidemic. I will add to this the fact that, we've seen, right, and there's some slides here. This slide I do like, and many of you may have seen it, that really talks about how the opioid epidemic kind of hit us in waves, starting really with the commonly prescribed sort of prescription opioid medications, where data started coming out in the early 2000s, showing how the emergency department visits related to these substances had gone up markedly in the previous several years. I think 2003 data showed that oxycodone-related visits had gone up like 450%, and hydrocodone-related visits had gone up 200%, roughly. And they continued to go up, right, until right about 2009 or so, when that started to sort of even out a little bit right around here, likely related to more education efforts, more legislations, etc. And perhaps unsurprisingly, that's when we saw this marked increase in the incidence of heroin-related overdoses. And I think heroin was the single substance that accounted for the highest increase in overdose mortalities between about 2010 and 2013 or 14, where the overdoses went up almost sixfold related to heroin over this period. And now we're really in this third wave of opioid overdose, right? Which is primarily illicitly manufactured fentanyl and its analogs that has continued to go up. There is this concept in the world of infectious diseases called a syndemic. And that's this idea that when kind of multiple pandemics collide and outcomes worsen for each of them. And, and I think many experts think that's really what we're seeing. And certainly at the ground level here in New Mexico, we've seen that, where I think COVID-19 has really adversely affected the outcomes. And I think according to CDC data, we saw over 100,000 unintentional overdose mortalities in a 12-month period, nationwide. So it's not getting any better, right, is really the key. And this is just some more New Mexico data that I've listed, for reference. And this looks at sort of, what drugs are found in unintentional overdose deaths. And really fentanyl is really rising. And that's really what this is showing, right? This is going up to 2018, the New Mexico data. But you can see that the two lines that are rising at the highest, kind of proportion is this blue line, which is fentanyl and analogs, really started rising around 2015 and has continued to go up. And methamphetamine, the green line, which also started rising right around then and really accelerated in the last 3 years or so after 2017 or so. And we're continuing to see rising mortalities related to these substances. Going forward, opioid dependence, opioid use disorder is associated with a number of adverse outcomes. We've talked about mortality a little bit already, right? The data is really all over the place. But if you really look at some of the good quality data, what you find is that compared to someone without an opioid use disorder, someone who has opioid use disorder is not in any treatment is at least 6 times more likely to die. The hazard ratio for mortality goes up at about 6-fold or so. And that's not just overdose mortalities, it's also all-cause mortalities, right? And some of the things that drive it include things like infections, abscesses, motor vehicle accidents, right? Trauma, etc. The other things to really keep in mind with opioid use disorder is infectious diseases, HIV and hepatitis C. I think of particular importance is hepatitis C, which is so prevalent. I think Dr. Jacobson, one of our other hub team members, can really tell you that, a little over probably half of our new patients at UNM's addictions and substance abuse programs are hepatitis C positive. So really important that we're screening for it and providing treatment if indicated. And there's a myriad of psychosocial challenges, right? And risks associated with opioid use disorders, including low employment, right? Crime, cost to society, etc. So I think it really winds up affecting our society in a pretty profound way, beyond just mortalities. So with that, I want to spend the rest of the time really talking about some basics of treatment perspectives and considerations. One of the things I want to draw attention to, right, is this term that, medication-assisted interventions or medication-assisted treatments. And I opted to leave it in for a reason. I think when we started our ECHO program with the grant from Agency for Healthcare Research and Quality, AHRQ, MAT was really how the grants had called for, right? Medication-assisted treatments. And so we had used it. But really over time, and so I left it in to really promote this discussion, to have this, have this discussion a little bit. Which is the idea that over time we've moved away from this term medication-assisted treatments, medication-assisted interventions. And really in my practice, I just use the word medications for opioid use disorders, or MOUD, right? Because I think the data as it's grown really seems to support the fact that when it comes to opioid use disorders, medications are critical. Medications play a central role. And by themselves, psychosocial interventions are actually not very helpful for people with opioid use disorders. Not to say that psychosocial interventions aren't helpful, right? I think many of our patients with opioid use disorders have other illnesses, other substance use disorders, other underlying psychiatric illness, where psychosocial interventions may actually be, in many cases, the treatments of choice, right? But I think the key is that medications help. And I really want to promote this idea, or at least put out this idea to the group, that we not delay starting someone on medications if they have an opioid use disorder. I think that's maybe the first take-home point in this first talk of the series, that if someone has opioid use disorder, we should make available one of our FDA-approved medications, right away, as soon as possible, even as we wait for psychosocial interventions to come in and sort of, be a part of the treatment plan, right? Over time, these are the slides that I think Dr. Maley does a wonderful job of, is this idea that, we've followed this pattern, right? Where addiction, substance use disorders have often been seen over the years either as criminal issues, right? There's a long history of that, or addiction as a moral problem, or failing. This view that addiction is the failing of willpower or weak character, and there is a deep history of substance use disorders being viewed through those lenses, right? And I would add to that I think there is also a long history of substance use disorders viewed through like a lens of xenophobia or racism. And there is also, which then in turn ties into this criminal lens, or the lens of crime. And those are some of the things that we as a society need to grapple with and start to unravel. Over time, this idea of addiction as a disease, and more recently, addiction as a complex, multifaceted condition, have taken hold. And I really like this view of addiction, substance use disorders as a complex, multifaceted condition, which is the viewpoint that addiction as psychological, physiological, and social environmental contributors, and ultimately is greater than the sum of its parts, because it is really the ultimate biopsychosocial process, right? We often talk about that in medicine, we talk about that in behavioral health, but substance use disorders are, at least in my view, my experience, kind of the ultimate biopsychosocial processes, where there is this rich interplay between your genes, your biology, and your environment. and even epigenetics, right, where environmental factors might turn on or off the expression of certain genes, which in turn influence outcomes and the disease trajectory. There is also, things like early availability of the substance, the cost, how it's used, the effect of the drug itself, ultimately affecting brain mechanisms and leading to the progression of the substance use disorder. So if my first take-home point for this 12-week series is that we not delay the initiation of an FDA-approved medication, the second really is that all substance use disorders, including opioid use disorders, are chronic conditions, right, that require chronic ongoing treatment. Recovery is possible. I don't know if any of you guys were listening to KUNM on the drive to work maybe a week or so ago, where they were highlighting a paper that actually came out about a year ago, I think last year, that pointed out, and it was a really well done study, and really pointed out that a majority of people who have a history of substance use disorders, all substance use disorders, actually go on to make a recovery as defined by SAMHSA. We just don't hear about those stories. But that recovery process can take a long time and may often be a lifelong process, right? And may or may not include sobriety. So I think there is a lot of hope. Recovery is not only possible, but it's even likely. We often just don't hear about it. We don't come across as clinicians. We often don't get the opportunity to work with those patients, right? We've known for a long time, for at least 2 decades plus, that substance use disorders are very similar to other chronic illnesses. This highlights a study that was published in the Journal of American Medical Association way back in 2000, done by Thomas McClellan, whose group compared, cocaine, nicotine, alcohol, and opiate addiction, to kind of quote unquote medical chronic diseases such as type 2 diabetes, hypertension, and asthma. Importantly, the first thing they found is that for all of these things, the heritability is similar. About half the contribution comes from the genetic impact, and the other 50% comes from the environment. So the contributions of environment and personal choice are comparable. And importantly, medication adherence rates and relapse rates are also similar, right? So it's no surprise that just like we would with diabetes or hypertension, long-term chronic disease management model, long-term maintenance treatments are the most effective. And episodic is not going to work. And yet, even in the year 2022, very often we continue to apply acute models, right, to what are essentially chronic illnesses, and expecting it to succeed, which is going to be very hard. This is just from that paper looking at relapse rates. Often there is this idea that, people with substance use disorders just keep relapsing, and there's this whole hidden curriculum that our students are exposed to. But if you look at the relapse rate, which in the paper was defined as needing to be readmitted to a higher level of care or to a hospital for restabilization, are actually no different compared to our patients with diabetes, hypertension, or asthma, right? We know that stigma plays a major role in recovery. That's another one of the main topics we want to introduce. We go into stigma in a lot more detail over a 12-week cycle. And we've also been able to do some good stigma trainings over the last year or so, where oftentimes, stigma is pervasive. A lot of people still think people with substance use disorders should get less priority, for example, in housing or healthcare or employment. And our patients are faced by these stigmas day in and day out. And importantly, healthcare providers are not immune from those stigmas. And I think that's why I really like that there's this Dr. Maley, ask for self-reflection, right? If you ever had any thoughts about your patients, that patients may have moral weakness, character flaws, or maybe untrustworthy, criminally involved. It's been shown that, people often place the blame of the substance use disorders on the patients themselves. There's that attribution blame. And all of these experiences combined lead to internalized stigma, where the stigma is turned inward by the person experiencing the stigma. And it's been shown that when that stigma is internalized, it leads to worse outcomes. It leads to people being less likely to seek treatment, to stay in treatment, have worse mental and physical health, have decreased employment and housing, poorer support system, as well as learned helplessness. And all of those things actually go against the concept of recovery and are direct barriers to recovery. So stigma, I think, is a major barrier that continues to be need to be addressed much better than we have done, right? So what works? So I think all of us, need to be actively combating stigma and taking an anti-stigma position. I think these are some of the recommendations, right, from American Academy of Addiction Psychiatry, showing that we need to treat the whole person, right? Holistic chronic treatment is important. And really medications for opioid use disorders form the mainstay. In general, for substance use disorders, we talk about combining that, of course, with learning new skills, social support, chronic care management. I think applying chronic care management model makes a lot of sense for substance use disorders, including opioid use disorders, right? If we use evidence-based treatments, we know that it leads to substantial improvement in reductions of use, increases in health, in social functioning, improvements in public health and safety. And really through improvement, if you're hoping for total abstinence, that model may work for some people, but does not work for everyone. But if you are working towards improving outcomes, right, that we might be able to meet more people where they are and work with them. Episodic use is not uncommon, right? It's not the exception. And often people go through multiple cycles of remission and recurrence of use, before they sort of get to a point where they're meeting their goals. So it requires active works across dimensions of wellness, including physical and emotional health, including relationships, right? That's social health, stability of living environment, engaging in community, deriving meaning in your life, and having a purpose in life, which are all actually components of recovery, which can be a lifelong process. I'm going to talk a little bit about psychosocial models of care, which has really shifted from an abstinence-based model to more of a kind of a harm reduction model over the last 3 decades or so, as I've already talked about, where the priority is placed on reducing harm, and our patients can do well, can even be in recovery and not be completely abstinent, right? Medications certainly have a role for that. I think this is a good introductory slide, based upon the stages of change. For me, the point I really want to highlight with this slide is that we need to do what we can to meet our patients where they are. If we're, only going to work with patients who are completely ready to be totally abstinent, we might miss a lot of patients who could still benefit from treatment engagement. So this really matches up different sort of psychosocial treatment strategies, right, with what stage of change they are. So for example, if you try to use a relapse prevention and relapse management strategy to someone who's pre-contemplative about total cessation, that's not going to be very appropriate. On the other hand, using motivational enhancement treatment, right, or strategies can really help people identify their goals and work through and work with some of the ambivalence they might be feeling about their goals. So really matching where they are, because patients really can be at any stage along this continuum and can go both ways, right? Can move back and forth. And we as clinicians need to meet our patients where they are, right? It's an outdated perspective to say patients have to be ready for treatment. What's not recommended? Detox alone, which for opioid use disorders has not been shown to improve any long-term outcomes. There is really no data right now when it comes to opioid use disorders, no compelling data for either individual psychodynamic or psychoanalytic therapy in isolation, or unstructured supportive individual therapy, or process-driven unstructured group therapy, or discharge from treatment in response to relapse or ongoing use. We should be intensifying treatment, not discharging patients, right? It's like saying if you're treating someone with diabetes and they come back with a hemoglobin A1C of 8.5, are you going to discharge them for being treatment non-compliant, or are you going to think about how can I help this patient? So apply that chronic disease model when in doubt. Confrontational approaches don't work very well. Acupuncture alone by itself has not been shown to be very helpful. Same with relaxation therapy or simply monitoring the urines without providing other interventions. Some of the psychosocial interventions that do carry evidence include motivational enhancement therapy, motivational interviewing, cognitive behavioral therapy, including and in particular relapse prevention techniques, right? Contingency management, which is so evidence-based and yet so sparsely used. Community reinforcement approach, 12-step, including 12-step facilitation, peer support programming can be helpful for many patients, as well as structured family and couples therapy. That brings us to introducing the idea of medications. We've got 3 FDA-approved medications. Methadone, which is our agonist treatment, has been around the longest. Buprenorphine, which is going to be the focus really over the next several weeks, which is our partial agonist, and naltrexone, both oral and injectable, are approved by the FDA. The injectable really seems to be much more efficacious, which is our antagonist treatment. Buprenorphine has been around since at least 2002 in the United States. Initially was doctors alone, but now, and thankfully with CARA, nurse practitioners and PAs can prescribe buprenorphine, albeit only after 24-hour training, whereas the training remains 8 hours for MDs and DOs. And under the Support Act, it's also now thankfully extended to include clinical nurse specialists, nurse anesthetists, nurse midwives, and that's really improved access, but still treatment barriers exist. So there is, as this slide points out, huge barriers to psychosocial treatment. The workforce is so, doesn't meet needs. You can see that over 3/4 of US states have unmet behavioral health needs, which are even more amplified when we think about SUD treatment. And that's even more the case in rural parts of the state, right? And SAMHSA really has advocated for building up the behavioral health workforce. So that's really what this slide is getting at. Methadone, of course, has treatment barriers because you can only receive it from an opioid treatment program. And those slots nationwide have largely remained about the same over the last 2 decades, even as the opioid epidemic has raged. So methadone really can be hard to access. Buprenorphine in theory offers many benefits, and we have seen improved access. This is a study from 2008 showing that after CARA was passed, patient capacity has gone up by over 200%, even up to 2018, but there are still gaps. In particular, I want to draw attention, this is also from 2018, these rural parts of the state with a waivered, rural parts of the country with a waivered provider, where even in 2018, only 43% about of rural counties have a waivered provider. In other words, over half do not. And this is a map showing exactly that. All the unshaded counties are the ones where there is not a single waivered provider. And this is as of 2018. And New Mexico, I think a couple more of these unshaded counties now do have a waivered provider. But I think per last count, there were still 5 New Mexico counties that lacked a buprenorphine waivered provider. That was the most recent I'd heard about it. So there's still a way to go. And finally, I will end with this. The most recent change to improve access is the new waiver, right? The exception from the U.S. Department of Health and Human Services, which did not take away the requirement for a buprenorphine X waiver, right? If you're gonna prescribe buprenorphine to treat opioid use disorder, you still need a waiver. But it changed the requirement for the X waiver, right? What it states now is that NPs, physicians, PAs, midwives can, with a DEA registration, can apply for an X waiver to treat up to 30 patients, even without completing the training course, and even without attesting to the provision of psychosocial treatment of counseling. If you plan to go over 30 patients, then you do need to complete the course, which we do, of course, offer as part of this ECHO. So that's the most recent, and we'll see how that influences things. But the hope is that will also lead to more prescribing. I will stop here. It's just after